Okay, great. So, all right. So, thanks everyone for another week. Passed that too quick. Uh, no new papers that I know from the group, but hopefully this bioarchive paper has been in Science Translation List for a long time, but it should be hopefully accepted soon. So we'll update that hopefully when we hear back from the editors. Just the regular updates. Just the one thing we talk about every week. People are interested. Al has been leading the group for these couple of interesting case reports related to long COVID. The patients have agreed to give us all the data on them to write a case report on them. So if people are interested, um, reach out to Al and I, and we could get you involved. There's lots of interesting data there related with one of the patients who's been unfortunately going through a lot of um, bad health experiencing long COVID. Okay, so let's dive
I
in.
would definitely
Oh, sorry. Go ahead.
look at that. Yeah, I'd love to.
Oh, hey, Bruce. Yeah, definitely. Yeah, send me an email, but I'll forget. But we'll include you. Okay, so some recent news papers that I'll go over. There hasn't been much this past week that I've seen, but one thing, this article came out in Nature talking about China's rolling waves every 6 months that people are showing since they gave up all their, like the rest of the world gave up all the restrictions and stuff. But currently, I guess there's a surge there for the XBB.1.5, which is where everyone, I guess they're lagging from the rest of the world because XBB.1.5 is the dominant strain here in the US and everywhere now, but then it's teetering down, as I'll show you, because other variants are coming up. But supposedly, according to this Nature article, that China seems to have this lag. 90, even though they have a high vaccination rate, they didn't talk about what type of vaccination they had. But um, the discussion is that even though the population is vaccinated and there's a rolling wave and this is going to cause more people to become infected and strain on the healthcare, but I guess the good thing is still, as we've seen with the XBB variants, the hospitalizations remain low, just the strain of healthcare. But how is this going to affect future variants and evolution? We'll see. This one paper came out, which I thought would be interested to the inflammation group here, because it's a title here, panoptosis, necroptosis. But this paper came out, I think, this past week. And
where is it, Austin? I can't see where's the paper?
Oh, here on the left right side. You see it on your screen.
It's the Journal of Infectious Diseases.
Okay. Yep. Exactly.
I got it. I see.
I got it. Okay, yeah. And I'll send you guys the slides, but I can put the link in the chat too. But yeah, so this paper looked at autopsies from tissues lung from the first in Italy from the very first wave, just like the autopsies patient data we have, and we're looking at, and then they did specific staining on the lungs and looked at different factors, and they basically saw that that some of the phenotype that they were related to COVID pneumonia, which is what they were focusing on, will be some of the key factors popping up is related to TNF alpha, PDK, and other factors, but mainly like panoptosis, pyroptosis, and necroptosis. But this is a figure from the paper looking at how panoptosis is related with what they're seeing in the staining and in the lungs, and further how that increases inflammation and increases like factors like TNF alpha. So,
can I make a quick comment on
yeah.
This is amazing because it is so important to the long COVID and the cancer. In our organoid models, starting from normal lung airway, the data identify and validate the type 2 cell as the origin for adenocarcinoma of the lung. Furthermore, the changes occur before the cancer arises. And what the cells do is suppress epigenetically every one of those death mechanisms. Mm-hmm. All the genes are silenced because the cells couldn't afford that. And so as their march for cancer, that's what they're doing. And this is amazing relevance for where the cancer starts, which is what you really want to know for risk early identifying long COVID.
So this could play into our cancer COVID long COVID conclave that we
absolutely has implication. I usually don't. I just wanted to bullet this for you because I'm sitting back here kind of amazed. Yeah.
So that's even more fuel for the fire for them. Yeah. Makes sense. I mean, I'll show
Steve,
you. Yeah, go ahead. I'm sorry.
Steve, could you, somehow I don't understand the cancer COVID link here.
Okay, so if you take a normal airway cell from the lung and culture that, starting completely normal, you expose it to cigarette smoke, and I don't want to go, I'm glad to present this at some time. The type 2 cell with deep molecular assays emerges as it goes along with where the changes are evolving that I just mentioned. And that cell is the origin cell for lung adenocarcinoma.
Okay.
And so the changes arise and they become selected for, and then the death genes get silenced before you ever get a cancer, because the cells don't want that. To march through this and head towards cancer, they got to get rid of all those death mechanisms associated with apoptosis. Does that help?
Yeah.
Yeah, this is pretty much what Steve outlined here is what they talk about here in this paper. They don't talk about cancer in this paper, though. So this is
They don't. That's amazing. They don't. But yeah.
Well, airway, HE2 cells are not airway cells. They're alveolar cells.
That's where this origin points to, down deep into the alveoli, because
They
they're
definitely can de-differentiate and replicate, and then go to type 1 cells and make more type 2 cells. And so I think it's in that like they de-differentiate as part of an inflammatory response, and then and get ready to repopulate the lung. If there's
that's exactly what the data are, Bruce, except they have to get rid of that death mechanism, and they're not going to repopulate anything in an abnormal way. That's the message. That's what the data shows.
For oncogenic transformation, but is that suppression of the apoptotic pathway part of normal regeneration following a viral infection? I don't know.
For killing infected cells, it sure could be.
Could a virus block any degree of that if there's if the cells feel like they're getting infected or something and want to die? Does a bad virus suppress that?
That would be a great way for the virus to do its evil job description and keep going.
Sure would.
Yeah.
put the link to the paper in the chat just in case they want to wait for the slide. So get the paper. So this is So that's interesting for this paper. And there's some actually later on. I'll show you some papers about long COVID that could be linked to exactly what you said, Steve and Bruce. This was a review, which is I think relevant again to the information, but also to the mitochondrial work that we're doing. And it came out just like a couple of days ago, so I'm sure people have seen it. But they did a pretty good review on metabolic alterations. I mean, they use the word mitochondria twice in the paper, but as Doug would say too, metabolism is heavily, of course, mitochondrial activity is about regulating all this metabolic activity, as we know. But they kind of highlight in this review a few different pathways. One being the glucose metabolism pathway. This is one of the diagrams looking at how inflammation, both innate immunity, is related with their idea of what's happening with SARS-CoV-2 infection. And then they have a sphingolipids version of this too, which I didn't show here, but they have this arachidonic acid metabolism too, which is related with anti-inflammatory process, which they're highlighting in their review. So if people wanted to take a look at it. There's some, and then they go on also talking at the very end of the paper about various drugs that could potentially target these mechanisms in metabolism that the virus is attacking, that they're claiming is attacking based on their literature comprehensive review. And this is some of the, in their abstract here, to talk about like ASM inhibitors and so on. And they also have a part talking about fatty acids, which is, I didn't talk about here, but they have another figure. That's why they talk about omega-3 fatty acids. And then Waldemar, who's not here, but his favorite 2DG, they talk about meaning. And then metformin, which I'm going to bring up in another study. And we've been seeing metformin's benefit for long COVID. They talk about that too.
Yeah, let's talk about that because it's theoretically totally reasonable. I haven't seen any evidence that it actually is for real.
There's one paper I'm going to show you in a second that is going to show you that possibly it is real. That just came out this past week, so I think it might be good news for metformin.
Well, there's a lot of good news.
Here it is.
Metformin, and it's been on my list to just try it for a long time, and I haven't gotten to it.
It's fairly harmless too. So, you know, it's cheap and harmless. But this is the paper here, so it kind of lead into nicely what you said, Bruce. So this paper just came out.
I actually don't know that it's really been adequately tested in autoimmune syndrome people.
Oh, that they didn't talk about in this paper. So this is a clinical trial they did from this woman from University of Minnesota. This paper just came out yesterday. What they did was a 2-week course of metformin given, and they're not talking about people who've had long COVID. They're talking about the acute phase. So they're saying if you got the acute phase, we're going to give you the metformin to prevent long COVID eventually. They don't know if it's going to be
That's
a good.
completely different.
What's that?
That's completely different.
Yeah. So they in this paper they're saying we don't know if if you have long COVID it's gonna improve it or help it, but they claim maybe it will, So, but what this is showing here, which is clear in this graphs and their charts they have, then there's a good size number, 1,100 people they included in their trial. This and their ages of the age variation 45 years.
Yeah, I'm already very suspect about this. But this is from the exact same start site, random control. Okay.
Yeah, exactly.
Okay, that's better. Usually
Yeah.
people do these kind of comparisons. They bootstrap their way into it, and then they
Right.
like a later phase of exposure that they're comparing to an earlier phase of exposure.
No, yeah, this one they went early on, just
Yeah.
random.
Okay.
So they had the placebo event, and then this is the blue one with that. And so they said, what happened later when they've tracked the patients from the different, they looked at these different strains too, from all the way to Omicron, vaccinated or not vaccinated. And then there were also, I guess, a study looking at ivermectin and fluvoxamine, which they said there's no effects, as we would expect, for long COVID or treatment, which is good, which we were expecting. But the one that did show was metformin versus, the placebo. And they saw that 40% had fewer long COVID diagnoses. And the long COVID diagnosis, again, was surveys. They had to give people. They didn't have any biomarker, but compared to the placebo, and this is, talking about that. So, and their cumulative long COVID ones, there's a table in this paper looking, all the stuff like fatigue and so on that people list as long COVID. Could be anything under the table that we know.
I'm trying to understand the relative risk for long COVID of Alpha versus Delta versus Omicron. Is that in this or?
Yeah, this is this table here. This is talking about people who received metformin, this column 1, people who received the matched placebo. And it looks like the
No.
favors.
That's
Yeah.
not what it's saying. It's just whether they had, which one they had, which variant
Right.
they had at the time of randomization. Okay, yeah.
Exactly.
Because the intrinsic risk of getting long COVID should be higher in Alpha versus Omicron. Right.
Yeah, they have a larger variance error bar there, so I guess I could account for that maybe.
No, that's not what there. It's just they only had one person in there that had a Alpha.
Oh, here you talked about right.
Is it correct that metformin principally acts by limiting gluconeogenesis hepatically, or is there other mechanisms?
I mean, originally it's for diabetes, so that's why they were looking at it, right?
No, I don't think that's its principal mechanism. I think it's no.
What does it do? How does it work?
That's-
Where's the leg?
I think Doug, do you think you wanted to?
I think.
Yeah,
it's
do you want me to comment or not?
Yeah,
Sure.
go ahead, Doug.
Yeah, so metformin, obviously the question of how it works has been hotly debated, but Judy Hirsch and people that are very knowledgeable about respiratory complex 1, I think have pretty convincingly agreed that it binds to respiratory complex 1. It changes the conformation of respiratory complex 1 from the active site, so-called A site, to the deactivated site called D site. They have slightly different properties. And one of the thoughts is that then alters the mitochondrial energetics just slightly, and that activates an enzyme called AMP kinase. And AMP kinase then phosphorylates another protein called PGC1 alpha, and that's a transcriptional coactivator for all the nuclear encoded genes for mitochondrial function. So the idea that in diabetes is that by a very subtle change in complex 1, you upregulate the biogenesis of mitochondria in general, and that then shifts energy metabolism from glycolysis back toward oxidative phosphorylation, and thus has a metabolic effect. Now, there are other people that have shown that in some way it affects also cyclic AMP. What is it called? Anyway, the enzyme that degrades cyclic AMP. I forget the name of it right now. And that also. Pardon?
Cyclic phosphodiesterase.
Yeah, phosphodiesterase. Thank you very much. Yes, phosphodiesterase. Certain phosphodiesterase isoforms may actually be inhibited, which would increase cyclic AMP. Cyclic AMP then is another way. It activates CREB, and CREB is a transcription factor that actually expresses PGC1 alpha, and thus in that way would give you the same result of an upregulation of oxidative phosphorylation. And then finally, we're working on the fact that maybe this mitochondrial complex 1D state has a different function than people know about, and that maybe that function is what's the metformins metformin and fenformin are interacting with. But we're trying to establish that in our mouse model of mitochondrial disease to see if we're right. But I think pretty much right now, complex 1 seems to be the target with secondary effects on cyclic AMP and AMP kinase metabolism.
So how does that end up differing from like sirolimus treatment, or any kind of an mTOR kind of mechanism?
So mTOR, when it's activated, it upregulates nutrient acquisition and drives things toward glycolysis. So all of the functions of mTOR are in nutrient acquisition and accumulation. But oxidative phosphorylation is the converse of that. That is to take nutrients and burn them to CO2 and oxygen. So if you upregulate mTOR, then you downregulate OXPHOS. And that's why rapamycin, which is an mTOR inhibitor, is now thought to be an important drug for increasing lifespan. Well, it is in model systems, because rapamycin inhibits mTOR, that blocks mTOR's activation of glycolysis, and that then is countered by the upregulation of OXPHOS.
So how would that interact then with metformin?
So the effect on metformin is, I think, through AMP kinase, and AMP kinase then phosphorylates, or what's the protein? It's the protein TS1 and 2, which are, I forget the genetic disease right now. Tuberous sclerosis. It phosphorylates tuberous sclerosis. That affects the activity of a G-coupled intermediate protein called RHIB, and RHIB then is an activator, I think, of mTOR. So the cascade is by inactivating TSP1 and 2, you don't activate RIB1, and that doesn't activate mTOR, and then you go back to making OXPHOS. That's what I remember.
So would rapamycin and metformin be cooperative, or potentially have extra toxicity, or?
Hypothetically. I don't know that anybody's tried to treat rats long-term with both rapamycin and metformin, but could be interesting. You want to give it to astronauts and we'll see. Right?
That's the next step. But yeah.
So anyway, like this graph says that there was some improvement with metformin.
Right.
Dr.
They
Peter.
didn't go into any detailed biology like I was discussing, so that's the next step.
No, that's why instead of being invisible, I thought I'd become visible in case you wanted to ask. But I think this is very useful for everything that we've been writing with Covert, because it really says that the key factor is the interaction between whether the virus wants to drive everything to glycolysis, and the host wants to drive everything to oxidative phosphorylation, and any drug that biases in favor of the host is going to be inhibitory to the virus. And I think that's what the graph shows.
I think there's a translation regulation aspect in all this too that is also shifted by the being on metformin, and the virus wants to kind of control who's getting translated.
Absolutely, and of course, mTOR system activates cytosolic protein synthesis, and so that all of these things are interconnected in how you're going to use energy. And so you're right. Certainly, translation of both the mitochondrial DNA and the cytosolic ribosome messenger RNAs are intimately related to this, and that all gets back to why we spend so much time on the integrated stress response, because that's the system that coordinates all of these different systems together.
That sounds
Sorry.
consistent.
Didn't mean to lecture.
No.
Great. Thanks. Yeah.
Thank you for the answer, Doug. I noticed Dr. Peter Attia recently on his YouTube channel said he stopped using metformin because he found a net loss of a pound a year of lean muscle mass
Yeah, I
over
would
a 10.
avoid Bill. I would avoid anecdotal evidence and people on YouTube. So,
Well,
so
the reality is that any of these drugs are going to are going to affect the body more generally. But the reason metformin is important is because people that have excessive blood glucose, that, in my opinion, overloads the respiratory chain, generates a lot of ROS, and the mitochondrial reactive oxygen species chronically poison the body. So if you can cut that down, your long-term benefit is much greater than the effect of metformin, which is going to partially inhibit mitochondrial function. So you're trading off a mild mitochondrial function for a very important physiological benefit. But I don't take metformin just because it would be fun. I don't think that's wise.
right.
So I parenthetically have to comment, Bruce and others, I'm transparent about the fact that I almost certainly have long COVID and got infected in December 2019. And that was after 20 years of taking metformin. So it didn't stop the infection. And it certainly does for blood sugar what Doug said, and that's the best reason to take it. I can't say it didn't mitigate the effects of the long COVID, because I've done very well compared to some people who suffer much more severely with it. So maybe it mitigated. But my point is, a case of one is a case of none, but it didn't stop me from getting infected, and it didn't stop me from almost certainly having key symptoms and key manifestations of long COVID. But I'm not saying it's not useful, and the biochemistry that Doug just described is whopping and accurate. Worth hearing the lecture.
What's your Steve? What's your exercise tolerance?
I'm an old codger who's doing push-ups. I'm lifting weights. I run a 5K, and I haven't seen. I've probably improved my muscle mass by discipline over the last few years. So it doesn't stop that. If I didn't do that, maybe I'd waste away. I don't know, but I do that.
I'm your control, Steve.
Okay, great. All right.
I don't do any of those things.
If
And
you don't have post-exertional malaise and exercise intolerance from kind of diminished cardiac activation potential, in response to exertion, those are mild aspects of the long COVID version you have that are, and a lot of people would pay big money to have.
And I alluded to that. I've been very fortunate, and I alluded to that. I've got the things, but yes.
It says here that metformin may cause lactic acidosis, but rarely. Doug, do you have a comment on that, just out of curiosity?
That follows from the fact that it drives the complex 1 from the hyperactive state to the partial deactivated state. And that complex 1's job is to oxidize NADH to NAD. And those electrons then flow from complex 1 to coenzyme Q to complex 3 to cytochrome C to complex 4 to oxygen. So if you impair complex 1, your NADH level increases. NADH then can reduce pyruvate, which is the glycolysis takes glucose through the glycolytic pathway to pyruvate. Pyruvate normally enters the mitochondria to create acetyl-CoA to drive the TCA cycle. But if you have an excess of NADH, then the NADH has to be reoxidized back to NAD or the whole system fails. So what happens is the pyruvate then is redirected away from the mitochondria, and it's reduced by the NADH to lactate, and the NAD then is reconstituted to drive metabolism. So then you're going to naturally bias your glucose metabolism and pyruvate into lactate as opposed to being burned in your mitochondria. But since anybody with diabetes has an excess of glucose, then they can generate a significant amount of lactate and still have plenty of pyruvate to drive their TCA cycle. So that is considered not pathologic relative to the benefit of metformin in relation to the treatments.
But wouldn't metformin, so I don't understand if it's slowing down oxphosphosis. I mean, how wouldn't that over time, why is Steve's, sample of 1, why isn't he really kind of lethargic because of or something, why hasn't it adversely affected him because you're slowing down oxphos?
Because of the really cool things we're currently studying. but my collaborator will kill me if I went on public about it right now. But there's complex 1 is not only complex but very interesting, and there's something else going on that's really neat. But I'll just have to wait till she gets the paper accepted, then I can.
But I do appreciate knowing how my mitochondria might be faring well through 20-some years.
Yeah, you have great mitochondria, Steve. No question about it.
There's something good.
We need to send your blood to Doug and see how well it is.
Anytime
we can immortalize you.
Well, okay, I'll send you blood.
There's going to be a fee.
I'll pay.
Okay, I'm sorry. I didn't mean to
No.
dominate.
Great discussion. No. Wonderful. Something that's related to long COVID and maybe mitochondrial issues, but here there's a paper that came out. This was earlier in May, but I just saw it recently, where they looked at study where they were looking at the lung and pulmonary conditions and how that might be with severe COVID relating to newer conditions that they're calling new, but I think we don't know it's not that new. But the team basically identified things related with basically IPF, fibrosis or idiopathic fibrosis, and how things might be developing in that case and causing breathing issues downstream. And their claim here, some of the key messages that came up from this paper, from these studies that they looked at, it's a review plus they looked at studies from medical records, saying that COPD didn't seem to might have an increase of symptoms. If you have COVID, it might increase your symptoms, but that wasn't the case. But COVID might be an onset for IPF, which probably not a surprise to people here. But they're saying this would be something people should pay attention to for the injury to the lungs. But this is the paper going over that. And here's some figures from that paper, because I figure in the review, this might be relative to inflammation group and what we're talking about in there, and also maybe mitochondria group. They don't talk about mitochondria too much, but they talk about, this is their idea. Injury, IPF is on this side, and how COVID similarity is similar to IPF on this side, the different factors involved, and how they can be remodeled. SARS-CoV-2 is remodeling the lung, like fibrosis. And mTOR is involved. That's what they're claiming. And this is, again...
I still don't understand what's the primary... I mean, sure, all this theory is totally reasonable, but what's the evidence that ILD is accelerated or new cases of it as a result of long COVID?
They're looking at basically patient data, like hospital records, and then they found basically IPF being prominently, or not IPF because it takes longer to develop, but fibrosis seems to be coming up more after COVID for a lot of these patients, or early onset of fibrosis, let's just say. So they didn't look at it molecularly. They kind of looked at the patient data, and they had like from some scans, CT scans from lungs from patients that they accumulated together. And then they said, okay, so say fibrosis is evident, and then they started digging into the literature. So purely like hypothesis and theory driven based on what the reviews have been said, and they came up with this idea. Whether it's accurate or not, you have to read the paper and seem to have a reasonable explanation behind it. But they had some evidence, CT scans, and evidence that from COVID patients that there is a higher number of fibrosis occurring from severe cases. Forget the percentages they said in here, but
Yeah, I mean, COVID pneumonia is very destructive, and or it
Yeah.
can be, and then of course you get a fibrosis response after that.
yeah. So this is like one of the ideas that they're comparing basically patient data from fibrosis to COVID, and talking about like the different hypoxic regions and hypoxia being increased and other things being increased that are similar to IPF or pulmonary fibrosis, I should say, not just IPF.
I'm just still, this is just too much like confusion and disorganization in their approach. I mean, it's just there is a subset of long COVID that have respiratory findings, but and breathlessness, but of those that are of any kind of a mechanism related to something that relates to the radiographic pattern or the specifics on the pulmonary function testing, or is it a kind of secondary to cardiac dysfunction? All of that stuff needs to get back here, and this is not helping.
Yeah, they didn't talk about. I mean, they didn't have any evidence of other than what's in the literature. So it's more they looked at the hospital and did a review. But yeah,
it's like it's a mixture of, if you glom everything here and everything here and everything here, some parts of it may or may not be correlated and related, but they're not giving that
right.
focus.
But yeah, I mean, there is some evidence from people in our group that people show, like Rob Schwartz showing some lung like he's done a study, or he's doing a study, I should say, from people who've died from other causes now, a year or so after, not COVID, but they've had COVID, and people have seen some of this data that Rob has shown, and he's been showing that there's increased fibrosis in those lungs from actually people that got an autopsy for that they shouldn't be having. Is a higher frequency from the age groups that they're looking at, and they're doing some molecular factors. So I guess we have to wait for the paper. Once they put that out, I think that might be some more direct evidence that you're looking for, because they're doing some really comprehensive study on this in these patients, and relating it to the people who had COVID versus people who died of other causes, never had COVID, or had maybe a mild case of COVID. It's interesting data he's shown us a couple of times in different meetings and environments. But that's the type of evidence I think you're looking for, Bruce, that we don't have yet.
Yeah, no, I'm looking for precision medicine within somebody who has these
Exactly.
this kind of presenting complaints, and then these focused lab tests give you this picture, and then here's some either histology or some on target biomarkers that really back up sort of what's the mechanism that's operative here that's addressable.
Yeah, I know. Yeah, that'd be nice.
By the way, metformin has recently been shown to be of benefit in some pulmonary fibrosis progression.
I gotta read those. Yeah, that's interesting. Another benefit. Metformin seems more and more to be like this miracle drug, benefit for all, and not that many side effects from what we know of.
Well, that's because it works on the mitochondria.
Yeah, there you go. But that's perfect. But so
we'll try it.
sorry,
Dan.
so-
Also reports of short-term gain and long-term loss.
Yeah, so now the different variants is going. This is updates in the variants. We know XBB.1.5 is dominant still, but other ones are creeping up. .1, .16, .1.9, .1. I guess now in China they're having their wave of 1.15 that we've already had. But the good news is, if you look at the wastewater, since case reporting is pretty unreliable everywhere, the wastewater is, I think, the most reliable. You can see the downward slope of cases in the wastewater, at least in the U.S. Regionally, it's all the same. You can see that they actually delineate which sequences are there. It's still the XBB, this dark, or what, the magenta pink, whatever you want to call it. This is XBB.1.5 is that, but then you can see the 1.9 and the 1.6 creeping up now that do that. And I just kind of focus on where I live, the county. You get these little bumps going up and down, but it's the overall trend down. If you look at other counties, it seems to be universally, and at least in the United States, the wastewater is showing that. So unless other people, wastewater experts here, have seen otherwise, this is what I've been seeing. And the variance in the U.S. again.
This graph was in the that's current date.
Yeah, this is from June 5th. They usually update every Tuesday, I think, or Wednesday. That was June 5th, Tuesday. So yeah. But then you have to wait till next on Tuesday or Monday. They'll have the next update every week.
But this level now it's higher than many previous troughs.
Yeah, I mean it's still going down, as you're saying. So it's a slow downward trend. Whether what happens next, I don't know, or if it's just going to plateau here. Yeah, it's still higher than zero and higher than. But at the peaks like Omicron, Delta, the things like that, it's lower than those peaks.
So, I mean, I know plenty of people are turning positive right now. Just over the last month, I probably heard of 10 people that have turned positive and gotten pretty sick. And,
yeah.
But
yeah, I mean that's the thing about hearing that too. But I guess the overall trend of wastewater is showing it's down.
Yeah, but the other way of looking at it is it's not even close to prior low trough levels, but everybody's acting like it's all done and there's nothing else, nothing to see here. And and then also nobody thinks there's any use of Paxlovid anymore for you'd have to twist arms to get access to it now. And that's also
that's unfortunate.
Complete ignorance.
Yeah, I agree. Because Paxlovid has been pretty much shown benefits of it, So, but we'll see what happens. Again, the wastewater is usually an indication 2 weeks what's going to happen down the road, and you see these bumps that happen. And as you said, Bruce, yeah, it's true. It's not zero, and it's still, it's pretty prominent. People are getting sick, but at least it's not these peaks that we saw previously. Yeah, this is the variant distribution. Again, it's XBB.1.5. The 1.16 is the one that was in India. 1.9.1 is the one that was in Singapore that caused their waves. But the hospitalizations remained low. The symptoms are pretty much the same. And I guess that the idea is that people probably, as I discussed the past few meetings, as the papers and articles coming out, people should probably get it if they haven't had their booster ever, they should get it. Obviously, probably everyone here has. But the 6-month waning period, people probably should think about getting another booster. But that's what my opinion is. I have to get one soon. But
I mean, this is really just and it's just a problem that is so pervasive that what people are worried about is not what they need to worry about. And so if they're worrying about, management of acute disease and you're going to get hospitalized and or at risk for dying, that's not the problem. That it's really, are you going to be left, with, dysfunctionality, and then are the people who have, some level of long COVID before, are they going to be significantly worsened by this? And should we be doing anything different than anybody of just saying, oh, woe is me for not for getting this now at this point? Right. If this is, you're not going to, your likelihood of going to the ICU or dying is low. Is that the end of your concerns? Most people think, yeah, that's it. And that's just so ignorant.
Yeah, I agree. No argument on my side of that. And that's what we're trying to promote. But most people don't care anymore, as you said. And they're like, well, we don't go to the hospital. That's it. It's fine. But that's not the case. Yeah. I guess there's been, again, I'm sure you've been following up, Bruce. A lot of people have. I've shown the past few weeks, like people, the data that's coming out, supposedly long COVID now is a 10% chance if you get COVID, but that's still, the numbers a little shaky. But there was a paper I presented a couple of weeks ago, a week ago, 2 weeks ago, whenever it was, talking about some pretty good numbers, saying it with, if someone got long COVID in the past, or COVID in the past 6 months, their chances of 10% now as opposed to 20 from previous waves. But that can change, as we know, because it's still early for the previous waves.
Yeah,
But,
I don't think the risk is really even at 10%. But if it's at 5%, that's for those people that have, life-altering long COVID. You want to, if you could do anything to prevent 5% of people from getting a life-altering disorder, that would be desirable. Yes, those people would be. If you have irreversible or apparently irreversible or extremely slowly reversible disease that limits your life, that's horrendous.
yeah, I agree.
The acute load shit is just, that's bullshit concern.
I agree.
And it's just such a, CDC and NIH are just negligent, and even WHO is probably more informed, but they're also not doing what they should do for humanity.
That's another topic over drinks and better to talk about, but yeah. But yeah, so I guess, yeah, overall globally, again, if you take hospital admission and ICUs are down, but again, case numbers are not very accurately reported, so we really don't know the cases that are happening, and topic that you bring up, Bruce, how that might be impacted. But this is it for the updates. I don't know if we could have more discussion. People want discussion on other things related.